All right. I'd like to thank everyone for joining and for sharing this hour. Hopefully we are true to it, but I'm sure with this expert panel that we will be. It's really exciting. This is the first time we've actually had both chapter authors, our consulting editor, as well as our section editor, all on
ultrasound. And I think that really kind of, changes people's outlooks on ultrasound. And I think one of the kind of thing that really kind of helps bridge that gap with, people that use ultrasound more or less is kind of really bring it down to the focus questions. And I think if you kind of come in with focused questions, it makes things just feel easier. You're not trying to like sift through that sea of, shades of gray to kind of interpret what do I need to see, what I need to do. You're saying kind of like what Sarah said, you find the IVC, is it huge or is it tiny? You look at the heart, is there fluid or not? I think when you kind of really kind of hone in on those focused questions, it kind of helps bridge that gap and get more people comfortable in trying to, use it when it's the highest yield. And I think it really is kind of that undifferentiated shock.
John, do you agree with that?
Yeah, I 100% agree. The undifferentiated shock patient is really the highest yield patient population where I think ultrasound can be helpful. Certainly there's time, and it all comes down to time, right? Like ultimately you have to make a decision on how to make an intervention quickly. And that's where these point of care tests are so valuable. If you have time to get a CAT scan, you have time to get, an ultrasound technician to, come down and scan then that's fine. But when you need to make a decision now, that's where ultrasound really is valuable.
Scott Weingart, I know you have said you don't carry a stethoscope around your neck. I've never actually seen you at the bedside, but you don't have to tell us if that's true or not.
No, it's of course. Please, there's no secrets here. Of course, it's totally true. I don't understand the utility of them anymore, except as a prop to make us look more professional as doctors. But I mean, what I'm going to say to this, Mike. Emergency medicine is dichotomized specialty, more so than any other specialty I know. And there's some people that are just half-assing it through their job, and there are some people that actually are committed to maximally resuscitating their sick patients. And it doesn't divide down academic or community lines. It doesn't divide by how many patients you see, because I have 75-year-old people I'm coaching who are masters of ultrasound. They self-taught, they went to the courses, and they're in tiny critical access hospitals. It's just in our specialty, more than any other I've seen, we allow a diversity of skill levels, and we allow people to get by and say, yeah, I don't really use ultrasound. Come on, it's beyond standard of care. It was standard of care like 30 years ago, to have the basics of ultrasound. But now, if you're not capable of doing an echo exam and a fast, you just shouldn't be in the specialty anymore.
I love having this philosophy in here with it, and the gauntlet has been thrown, right? So
yeah, I'm happy to take on anyone who's going to debate that they don't need ultrasound in emergency medicine.
Right. Those are fighting words, right? Well, Sarah, I'm going to bring you back in here, not about ultrasound, because I know that you agree with these folks on that also, although certainly feel free to add anything you want. But I will tell you that this patient had an EKG done, and it showed low voltage. And we'll say that it showed some electrical alternans also, but just say, for example, it showed just the low voltage, or that's the main thing that we saw when we looked at it. This is a really nice table that Ben Cooper from University of Texas, who is also the author of EKG Stampede, and shout out to him, that he came up with, or maybe he sort of incorporated this from some other places. And also one of the things that he put in the article in the Journal of Urgent Care Medicine on an EKG lesson. But I think it's a really nice way that we break down causes of low voltage, either increased impedance or decreased impulse generation. So Sarah, will you just sort of briefly, for 60 seconds, walk us through this table here?
I'm actually not going to do that because I think this table's too long for
All right,
situation that we have to deal with. Look at this patient. So the question I'm asking of the ECG, and Bob Stenberg, I tortured him for all of his years of residency. I mean, I read ECGs. I'm actually probably better at ECG reading than I am with ultrasound. And so I can create all kinds of stories from ECGs, and I love ECGs. I love ultrasound too, but I love ECGs probably more. And so I look at the ECG and I go, the voltage is low. That's all I ask for any trainee to recognize. And then the first thing you do is you send a medical student to go get the old EKG. This guy was just admitted to the hospital, had a heart attack. He's got ECGs you can find. And just see, look at his body habitus. He was a huge guy. Then yes, the dampening effect of increased layers of fluid, fat, and air between the heart and the recording load is one of the primary reasons for, and that's so if there's body habitus, well, it's not going to change in a couple weeks, and if it's not that, then there's air or fluid. there's loss of viable myocardium. And so that's going to be somebody if he'd had, so you're going to have loss of voltage, but it's going to be regional. It's not going to be diffusely throughout the whole ECG. And then there's diffuse infiltration of the heart or mixed edematous involvement of the heart, which can cause decreased voltage. But those are conditions that didn't happen yesterday. And so if he had amyloid or sarcoid or thyroid disease, this is not a new thing. So I'm already thinking, what's going to cause hypotension? And so it's either going to be, so I'm looking at the ECG asking, saying, my first thing would be looking for ischemic disease since he just had a heart attack, right? And so saying, is there ST segment elevation? Is there loss of voltage in areas that would suggest that he has maybe aneurysm, or he's just got a predicting, anticipating he may have a poor EF? But I'm seeing diffuse low voltage, and I'm like, that fits in I'm developing a story, right? And that's leading me down the garden path and dragging me down in one way even further and saying, where is that ultrasound machine? Yeah.
Well, I love your answer, because what you're doing is you're like, hey, enough talking. Let's have some action, right? Let's get back to the patient and figure out actually what's going on there. And also putting the timeliness, which is always hard in one of these conferences, right? When we're talking about a patient and we're sitting back in our chairs thinking about it. But, at the bedside, there's a timeliness component that you can't just snap your fingers and have a test result as well. You need to figure out which test you want to even start with. I'm going to, though, go one more quick branch point here, and this would be for anyone that wants. Charles Werlow from Lehigh asks, isn't it true that the RV will be dilated post-arrest if the patient arrested and can be mistaken for massive PE when it's not there? How do you distinguish whether a patient has a PE or not in that scenario? And anybody who would want to answer that question, feel free to go ahead.
Yeah, I just put it in the chat, but it loses its specificity during the arrest itself. But in the post-arrest, which is what Charles is asking for, it pretty rapidly regains its utility for assessing elevated pulmonary artery pressure and RV dilation. So yeah, you can't use it during the arrest to say, oh my God, the RV's big, give this patient thrombolytics. We've learned that lesson, thankfully. But after the arrest, you're going to regain the utility of ultrasound.
And I hadn't scrolled enough to see your answer, Scott, but we might as well just throw this other one out also. And Shauna Leach says, why not just start with blood? We know this guy's hypotensive. Is it going to hurt anything? And Scott, expand on your answer just a little bit.
Yeah, I'll say what I said. I'm curious to hear what John has to say. I'd need a little bit more. My spidey sense is not tingling yet for bleeding, though it's certainly in the differential. But the only cavity we haven't evaluated yet after doing a good rush exam should be the retroperitoneum. And you certainly could have a spontaneous, or in this guy, it wouldn't be spontaneous. It would be anticoagulant and trauma. So all of that mixed together. So we certainly could, but there's other things that are, making me want to rule out first. But, if I gave him vasopressors and he's not getting better after all the normal stuff like the fluids, then certainly I consider blood products to temporize to get him to CT scan. John?
Yeah, no, I agree. I mean, I also would need something else. And again, bring the time component in there, right? Like, what are you going to do? Wait for the volume for your type and cross, your uncross match blood, whatever. Like, this person needs an intervention now. And then certainly if you want to put the order in and then have it in your back pocket, like, should you need it in an hour or 30 minutes or whatever it's going to take, great. Put in the order, get it down here. We'll send it back if we don't need it. But in terms of, I wouldn't wait. I wouldn't just give it empirically at this point.
Okay, so let's find out what happened with this patient. And this was just the initial part. It sounds like it was a PA, saw the patient, the physician obviously is intimately involved very, very quickly, sees the low voltage. But what they do, instead of actually doing an ultrasound themselves, actually orders a hospital ultrasound. And so here's the medical decision-making note. I reviewed the chest x-ray, showed an enlarged heart. So now, Sarah, we also have not only the low voltage, history of trauma, the anticoagulation, but also at least on a chest x-ray, not incredibly specific, but certainly concerning, large heart. The pressure now is a little bit lower, 72 systolic, hemoglobin 9.9. Of course, this is sort of an acute sort of situation here. Bicarb 16, blood sugar, creat is 5.6, and I believe that that's new renal failure for the patient, and the INR is 8.4. The echocardiogram is done and shows a large, what they just remarked simply as a large pericardial effusion. So why don't we now move to our decision point B. let's get ourselves back to the bedside. Sarah, you had sent me a couple of videos. Do you want to get back to the bedside now and talk more about this patient, or do you want to take a little branch point and talk about the videos and the other case that you had? We could just briefly talk about the one that you had sent to me.
I sent you two, but I think the one that is more likely what they did see on that echo, which we didn't provide that. The other ones, if you didn't get them moving, I sent you the new clips, but they're kind of, that's, we can take that later. So I think the big thing with the ultrasound, as we've all been alluding to, is that this is the patient for whom an ultrasound is going to be very high yield. If you find something, it's probably the problem. Back to the person who was asking about the dilated RV, there's a whole differential dilated RVs. Half our COPD patients will have dilated RVs and they live with that all the time. But in someone who's crashing hypotensive, you know, and you can't find anything else, you got to start thinking, could this be a PE? I mean, you have to do something now. And so the ultrasound here is we've already, well, that's that one I was talking about. So this was a, can we get these to move? Because I sent you a thing and I don't know if they can move.
Yeah, and you know, on the
there we go.
Is it moving?
No.
Not enough.
With a frame refresh rate.
Yeah, there we go.
That's the one. That one moves. There, that one moves. Okay, so this is probably what they saw because this is a subxiphoid view. That's liver at the top of the screen, and there's the RV is where the arrow is, and you can see that the RV is squished. And the whole physiology behind a pericardial effusion with tamponade physiology is that the and so you can remember all these different elements, and Bob, you could probably do a better job than I can, and all the different things that will identify tamponade physiology. But if you understand the fact that the LV fills a little bit sooner than the RV does, and because it's big and muscular, and the RV is little, skinny, and wimpy, the RV loses, just especially when there's a finite amount of space for it to expand in. And so now when you add on, so that's why one of the things you're looking for is an RV that can't fill. And so if we can run that clip one more time, you can see the RV, which is at the top of the screen, just can't fill. And right above it is a clot. And it's sitting there, this clot, which is, again, probably what this guy had, even though he was over anticoagulated, he still probably had some element of clot because this didn't happen just right this second. He came in with this. And so, you know, when you think about when you're interpreting pericardial effusions, the small ones, as Bob totally correctly alluded to, is the fact that the big, huge effusions are probably not going to be the reason why someone's frankly dying in front of you. They happened over time. They had a long time to develop, and it's going to be usually cancer, or I call them large diseases, all the patients that have double-stranded and single-stranded RNA and DNAs who now have effusive pericarditis, and those will develop huge effusions over time that will make them dyspneic and have soft pressures, but not make them crashing. Crashing is someone who is bleeding into it, and so bleeding into the space, has an acute infection that's being involved. And so the patients that I've seen is, one, look for clot, because that could be a clue. Two is the second case, which I think are not moving. And Mike, can you move that down just to the one? Mike, can you move it down to the next clip?
Oh, yeah.
So the next one. Yeah, so this was a patient before that. Go back. Well, before that. This is all. So this is a patient who came in with chest pain, saying his face is crumbling. Not that one. No, the one before, with the two clips. No.
I'm getting there. Is that it?
Yeah, that one. Yeah, so you can see he had, on the echo that I did, he had a huge aortic root. And I was concerned, you can see a dissection flap in his IVC, which is in the image on the right. And I'm calling CT surgery because I was worried about, yes, I knew he had a dissection. And then he became unresponsive. And so the next clip, you could go to that one. That one. So you did have it alive. But it didn't look much different when it's moving because of the fact that he had, you can see he developed this huge pericardial effusion. Not that one. Not that one.
Okay.
Next one. And there's that one. But then the next clip,
Okay.
that one, just stay there. There it is. So this is live and this is moving. It's a big pericardial effusion. And so, and you can see there's clot forming within it. But so my colleague and residents were all ready to do a pericardial effusion. But what you have to notice is I said, no, there's no value in that, because what's missing here? What's missing here is the fact that the heart's not beating. And so this patient had dissection that obviously involved one of the coronary arteries. And so the patient was in true PEA, and the pericardial effusion was just the fact that he is now bled into his pericardial sac. So there are nuances when you're looking at who's going to benefit from an intervention who has a pericardial effusion. And one is making sure you didn't stick the needle in the clot. And that's something that I've seen done when people can't aspirate because the needle's stuck in the clot. I don't know if my colleagues here have ever had that issue, but you need to do agitated saline or something to identify that the needle's in the space where when you draw back, or you have a big enough needle that you draw back, and then that you're actually drawing back fluid that's free moving and not clot. And second is that I've seen this now 3 times where someone has a pericardial effusion due to a thoracic aneurysm, and they ended up having a heart that's not moving. So that's the problem, not the pericardial effusion. So in these sick patients, there are nuances, and those are the 2 most commonly that I've encountered. I'd love to hear my colleagues' other stories or experiences.
Right. So let me do this. And these were like invaluable having these on here, just to reorient all of us. So those were some patients that Sarah had seen. There were some good ultrasounds, and I'm really glad that we included those on there, because that's a really important point. Obviously, you try to get in there, it's like, hey, I'm a brilliant, you're proceduralist, and then I don't get any blood out, right? I saw it on the ultrasound. Why is it not coming out? So let's do this. We talked a little bit about how we can differentiate between tamponade and effusion in some ways. We talked about labs. Let me throw 3 questions out that we'll talk about through the remainder of our discussion here. The first would be, very briefly, we can talk about this anticoagulated patient and PCC. The second thing is, I really want to get a very granular level as far as indications for emergent pericardiocentesis, because we all have patients that are hypotensive-ish or maybe tachycardic-ish. They're talking to us, but then you have that same patient that's in a rural location that's 2 hours from some sort of main tertiary care center. So I want to get to the indications for that pericardiocentesis as well, thinking about different type of practice environments. And then finally, let's talk about specifically how we do that pericardiocentesis. So John, let me direct things back to you, just as far as the fact that we know that this patient has elevated INR, it's 8.4. We have obviously hypotension, tachycardia. How are you, even before you consider whether you're doing some sort of procedure like a pericardiocentesis, or if you're a thoracic surgeon is seeing a patient in the bed next door, before you even do that, what are you doing to address this elevation in the INR?
Yeah, so I think that you have to use your clinical judgment here in terms of, let's put some things together, right? And so in a patient who you're concerned of early, or in this case, he's clinically in tamponade, what does this patient need for resuscitation, and how can I kind of augment that? And so volume is really the key here for temporizing the patient in order to bridge to a definitive procedure. And I'm sure we'll talk about that in a little bit. So in that case, I'd call the blood bank, ask for, O positive, uncross-matched FFP, give me 2 units out, 600 cc's of FFP, that I can start bringing this INR down while at the same time resuscitating my patient with a little bit more volume. Certainly there's other ways that you can reverse this INR. And also it's important to recognize this guy's on dual antiplatelet therapy too, right? So his platelets are dysfunctional on top of it. And it's basically like they're just floating around, not sticking to anything. And so how do I address that at all? And I'd probably order additional platelets to give to this patient as well, because, as we all know, his aspirin irreversibly binds. Plavix is going to, partially bind in competitive to receptors for those platelets to be activated. So I'm probably giving this guy platelets too. And right there, I got a liter of volume that's going to go in this patient. If I have to give him more than that, well, this patient should have already had a procedure done. And so that's where I'm kind of starting. There's certainly, you can give things, PCC is 3 or 4 factor PCC is something that is generally available at most, I think, emergency departments now to emergently reverse INR in anticoagulated patients who are bleeding. But at the same time, you can reverse it. Absolutely, you could. But I'd spend more time doing other things than trying to get 50 mg per kg of, PCC to this patient. This patient needs volume. It's not like a head bleed where you want to limit the amount of volume that you give to these patients per se. You want to get it reversed fast, because if they're actively bleeding in their head, it's a closed fixed space that you can't access as an emergency physician. You can, in this case, with a pericardiocentesis, a window, or an OR, with a surgeon. So I'd focus on giving the volume for reversal.
Scott, let's think about those different things. We talk about FFP and or PCC.
Yeah.
Volume, 1 liter is where sort of John sort of drew that line, and then sort of bridging us into that indication for pericardiocentesis.
I will respectfully disagree with John. This guy's INR is 8. The literature tells us, I think, very cleanly that the amount of FFP you'll need to get this patient anywhere near a place that I'd be happy to stick things into their body would be 8 to 10 units of FFP. I agree the patient needs volume. They don't need that much volume. And the time it takes to get that in, the time it takes for your blood bank to mobilize that is more time than I want to take in this hypotensive patient with pericardiocentesis. So I completely agree with John of giving the volume, but I could give that separate from the complete reversal of the INR. Now, John very adroitly brought up the issue that is the difficult one to ask yourself, which is, should we reverse this patient's platelet? Because they just had a stent, and obviously the pericardial tamponade weighs more heavily on my mind than a stent thrombosis. But can I get away with not reversing the platelet stuff? That's the thing that would keep me up for a little while thinking. But certainly, I would be giving this patient full PCC reversal instantaneously. Give them the volume John said, and then give a think on whether I want to reverse with platelets or not, knowing that giving the platelets probably won't fully reverse them. So I'd be in good shape. My chart would look good. I wouldn't get sued. And so I probably would give the platelets, knowing that they would still retain some of that antiplatelet effect from their dual antiplatelet agents.
So let me address really the elephant in the room, which is this pericardiocentesis. The question, when we think about PCC, I mean, hopefully that's going to be pretty quick. I don't know, 30, 60 minutes, maybe 45 to 60 minutes.
It should take you minutes to get in, and then 10 minutes after it's in, you have full reversal. 10 minutes is what you're looking at.
So way quicker than that, obviously, then. So there's no waiting by the time you're setting stuff up, probably.
No. By the time
you are ready to go. Done. Okay, awesome. So we say we've given our PCC, we've given a liter of fluid. The patient still has similar vital signs, blood pressure 72. Does it change your mind at all as far as indication? I'd like to hear everyone's thoughts on this, with either the location that you're at, if there's any backup thoracic surgery, night versus day, maybe even people who work in lower volume EDs who haven't done a pericardiocentesis in several years. Because even though everyone can, and Scott, I'll sort of call you out in sort of a funny way on this a little bit, absolutely, you got time, you got days off. Everyone's got days off. Take an ultrasound course if you don't feel comfortable. But, if you haven't done a pericardiocentesis for a while, maybe you could get yourself to a sim lab or take a course, but maybe you just don't have that comfort with the procedure. So I know it's a sort of a long rambling question, but where are we at with indications for pericardiocentesis as far as you're concerned? Then we can go around and get everyone's thoughts on that.
Sarah seems desperate, so I'm going to cede the floor to her before I say anything.
Not desperate. I'm older than all of you. And I did a lot of pericardiocentesis without ultrasound, even when I was a cardiology fellow. And so, so I've done a lot of them. And so, in those days, you did them at the end of the arrest, before you called the arrest, and that's the indication for it. And I think that what I want to try to do, because I know we have participants on this session that are not in academic centers, some do, but there's a whole world out there of saying, okay, I know I'm supposed to do it. I'm scared. I'm nervous. And I just, the thing that makes ED physicians is that we sometimes have to move ahead with a paucity of data and lack of definitive or full experience, and just go for it. And that's kind of, if you're in the right specialty, that's kind of part of our genetic makeup. And so once you decide, this is somebody who they're sick. You have to do something. You put the probe on, you see an infusion. You don't really need to go through, is this, I'm looking for right atrial systolic collapse versus right ventricular end-diastolic. You don't need to do that. It's an infusion. It's got a clot in it. I'm sure it did. He's anticoagulated. You order the PCC saying, I'm going to protect myself. I'm going to get the biggest damn needle I can find. And where the hell do I go? And I really want to support people. That's the right thing to do because they'll get better so quickly. And sort of worrying about where's the central line kit? Where's the pericardiocentesis kit? I mean, you need to save this person's life. And so you need to make sure that if you're sticking a needle in a body part that is potentially bloody, that you probably have their coags fixed. And so I would go absolutely with PCCs and then go and stick a needle in and fluid back. And then when you pull the fluid back, their pressures will come up pretty quickly and do it under ultrasound so you know where the friggin' needle's going. And then sorry, I'm not supposed to say that, I'm sure, but, and then you can take some time once the pressure's up, because that's like a rapid fix. That's like one of those great things we do in emergency medicine. Like you give it and it gets better. It's like calcium and hyperkalemia, it just gets better. And then you could take your time calling the cardiologist in to definitive or put the central line in or whatever. So, and I'll let my colleagues talk about that, but I want to keep it kind of simple, stupid, and I'm not insulting my colleagues, but we need to go with what's the problem and what do I need to fix and fix it now.
Yeah, and so just to be very clear, I know Craig Krause, thanks for your comment here that we should not, in this day and age, do a pericardiocentesis without an ultrasound. Sarah, I think you were just saying you had done plenty in the past, but I would assume you agree doing that with ultrasound now is the best way to go.
Oh, yeah.
Okay. All
No,
right.
I did it when people were before we called the code. So yeah, I can't even imagine. I don't like putting needles in body parts that I can't see where the needle's going. I am so done with that.
Okay. Hey, Bob, I know you've been sort of sidelined for just a minute here. What are your thoughts on indications for pericardiocentesis?
I think it is tough. I mean, if they're in arrest, peri-arrest, if they're in, profound shock, I think the right answer is to stick a needle in there. And then, I think it as you were highlighting, it kind of forms layers of gray in terms of how close you are to a CT surgeon, if it's if they need that, or, some interventionalist. And I think the further you are away from that interventionalist and the further the transfer needs to happen, I think the more realistic you have to think about doing that. And, sometimes I do think it's kind of objective when you're kind of like working through, kind of some confusion. Those in the chapter that we included the cardiology guidelines in terms of going through like kind of objective point system, kind of say how emergent is this, and if it's really tough to pin down, I always recommend kind of calling cardiology. They kind of have some support and someone else along with you, but I do feel like sometimes it is kind of nice to have something objective in that scoring system if it's kind of tough to pin down. I think that can be helpful to kind of navigate that that tough one. But I think the further you are out from someone else that can do that, I think the harder you have to think about sticking a needle there to temporize them to ensure that they have a safe transport.
Right. So the further the CT surgeon is away makes you more inclined to do that. So why don't we now go? I'm going to have the same question, and then we'll end with some of tips and tricks for doing the pericardiocentesis. And Charles, thanks for that question with that. We're going to end with that, and then we'll have everyone give some take-home points here. but just John, in all fairness, so you can disagree with Scott, why don't we have Scott go first, and then you can do the last one. So Scott, I know you sort of deferred the question a little bit to Sarah because she was ready for that answer, but give me some other thoughts you had. We talked about this at the MCRIT time that we would talk about it too, but you have some specific thoughts on not doing it too quickly, but not waiting too long.
Yeah, look, you're going to have to make a judgment call, and Rob's points are well taken. That if it's a 3-hour transport, Sarah said you take out a couple cc's, the patient gets better. She's absolutely right. And by the same token, you add a couple of cc's, the patient bleeds just a little bit more. It's not a incremental increase in their vital sign decline. They just drop off a cliff sometimes. So if that happens during transport, obviously the medics are not going to be able to do a pericardiocentesis. It's a big problem. So yeah, you really got to weigh everything. But I want to see the response to our temporizing measures because I've been surprised. I've had patients at death's door and we've given them fluids. They look much better. And then this is like considered, anathema. It's not supposed to work. You're not even supposed to do it. But putting these tamponade patients on vasopressors has temporized some of these patients insanely. Like, we were getting ready to do a crash one and then they waited 2 hours for cardiology to open up the lab and drain them with perfect vital signs. So, and they didn't respond to the fluids. So I've lost all, feelings on don't ever put norepi on a tamponade patient. Definitely do it. And it's probably because we used to think it only constricted the arterial side. Most of its response is constricting the venous side. You're actually augmenting the venous return to the heart and temporizing that tamponade pressure. So you can get them in a much better state. So yeah, luckily I don't transfer patients. I do it, in my own shop. It's a lot easier. I don't have to make the hard decisions that my colleagues in the transferring centers have to make.
John?
Yeah, no, I agree. And I think the point about vasopressors is important to clarify here. This guy's probably in mixed shock at this point, right? Like his renal function is so bad because he's probably been shocked for the past couple of days and finally presenting. And we all know that patients may start out with one form of shock, but eventually they all get the vasoplegic as they've been in shock for a while. And so there probably is some reduction in systemic vascular resistance here that needs a vasopressor. And, ultimately tamponade's a clinical diagnosis, right? Like is this patient responsive to their clinical interventions? If you give them volume and they're not, you can use simple objective measures like, your IVC dilation, your tricuspid inflow variation greater than 30, 40%, mitral valve inflow variation at 25%, and impress your cardiologist. But ultimately, this patient here that we're talking about right now needs a procedure. Now, the only thing I'd be worried about, and this drives me batty, and it's one, don't wait for the AC reversal to do a procedure that's needed, right? Like, do the procedure. If you have an ultrasound, get it done, save the patient. It's those deferred, I'm just going to kick it down the line, and then that patient dies. Number two, if you see a clot, this patient needs a surgeon, not a needle. Your needle is only in order to put volume in the pericardial space, it's just going to make it worse to try to flush it out. This patient needs an open procedure. They need a window. Pericardiocentesis is going to have limited value here. So, I think that there's a definitely nuance here as you get to the different layers. But ultimately, if we're going to keep it simple, if the patient is not responding to your initial volume resuscitation and even pressors and remains in shock, that patient needs a definitive procedure.
So why don't we do this? I want to have like legit 30 seconds for each person, just a tip and a trick, maybe something you would not do again, or something that you always recommend when doing a pericardiocentesis. Rob, why don't you start?
One thing to really consider, especially in adults, if you're going subcostal, you're looking at like a 6 to 8 centimeter distance to travel. So I've definitely one time in the past gone in with like your standard central line, finer needle, and I could not get into pericardial space. So one thing is to make sure you have a long enough needle. Also, too, if you have the ability, the fluid's going to be sloshing around. It's dependent, right? So if you can sit them up, you're going to bring the fluid closer for you to access, and should hopefully give you potentially a better window. And the last thing I would say is, personally, I really like to go apical if I'm doing these, because if you look at apical, the number one complication of that is a pneumothorax, and I know how to fix that. So, if you look at some other complications, peristernal, you talk about hitting the internal memory, talk about hitting the LAD, and I love the part about the apical. So if you poke anything you don't want to poke, it's probably gonna be a pneumothorax, and that just gets a picked out, which you can fix.
Okay, Sarah, why don't you give us like a 30-second thought on pericardiocentesis, tips and tricks?
So I agree with Bob. I think that it's just lowering your threshold. We stick needles in lots of body parts, and the great thing with ultrasound is that you can put the needle in wherever you see the fluid closest to the probe, because there's nothing there except for intercostal muscles. The big thing is to stay away from the memories, so go a little bit laterally. Apical is, I know there was a question there, and yes, I think we're all now advocating going where there's the most fluid next to the probe, and just go over the ribs, so that you remember the neurovascular bundles on the inferior aspect of the ribs. So just hit the rib, go over it toward the fluid, and you'll be there. Okay. And so I think somebody else had put a question about the clot and being that part of a thoracic aneurysm, and I know that you commented on it, and I think that yes, someone who's bleeding from their aneurysm into their pericardial sac, they need a surgeon, and anything short of that is going to be temporizing and probably not definitively successful. But I've seen in patients I've seen clots in patients who had complications from a cardiac cath, who've had trauma, and they've had hemodynamically compromising effusions. And so when they're crashing, yes, it doesn't hurt. You're not, as long as you can see where you're going, you're reversing anticoagulation and using ultrasound, it's not that dangerous a procedure.
Perfect. So Sarah, we're going to use that as your closing comment. I'm going to ask
Yes.
the other three 40 seconds each, and then I'm going to take 30 seconds to summarize and give the QR code here so we end exactly at 9 o'clock. John Greenwood, can you give us a 40-second, just the main things take away from this case, ways that we can improve care at the bedside?
Yeah, absolutely. Everyone's done a really good job here in highlighting the role of ultrasound, resuscitation. If I could take our minds outside of this box for just 1 second, as we think about the entire patient, it's not uncommon these patients will be in respiratory distress, right? Like they're in shock. They're trying to, blow off CO2, correct their acidosis. One thing you should not do ever is put this patient on positive pressure ventilation or try to intubate this patient. That's going to be a clean kill. It's just going to drop the preload even more, and you're going to be in a whole lot of trouble. And at the end of the day, bottom line is moving slow is fast. There's nothing more that takes more time. If you're going to say, I don't need to do ultrasound, it's finding or making a wrong diagnosis, doing unnecessary interventions, calling unnecessary consults. Take the time to learn the ultrasound because it will save you time on the back end for making a lot of unnecessary mistakes.
Awesome. Bob?
Just the points on the ultrasound. Use the ultrasound. If you're intimidated by it, use your focus questions so you don't feel as intimidated by that. So focus questions, is there an effusion? Is the heart beating? How's the squeeze? So use your focus questions. When you're looking for an effusion, one view is no view. Make sure you're looking from a couple different spots to make sure that you aren't missing some huge effusion because it can sometimes be somewhat sneaky. And I think some other things too is just when we kind of talk about the INR and kind of the reversal thing, I think kind of looking at your shop and actually having a game plan in terms of how you're going to go about reversing this scenario can be super helpful. Whether or not you're going to do an upfront fixed dose PCC or you're try to get a point of care INR, but I think having some plan or some kind of protocol in your shop to kind of have a plan about how you're going to rapidly reverse these people if you don't have that is going to be something to kind of help you cognitively offload these things when you don't want to be kind of like putzing around, fighting around with how you're going to go about that. So you can kind of focus on the resuscitation and trying to fix the person.
Love it. Scott, take home points.
Well, I'll just tell you how I do pericardiocentesis as my last point because I think that's important. Now, you do it however you can get it done if you don't have this equipment, but I'll tell you in my mind the ideal, which is echogenic needle micropuncture kit, anterior chest as long as there's a pocket of fluid to see it. Find that needle in there, put the thin wire in, and now put in the 18-gauge micropuncture. Blow in some saline. Make sure before you dilate up that you're actually in the right space, that you're in the pericardium and not inside the heart itself, and then dilate up to some kind of pigtail, whether it be an 8, 12 French pigtail. Once you now know you're in the space, that's a very safe thing to do, and that will get out clots. If you get an 8.5, 12 French in there, you can pull out clots. And I agree with John, if they're bleeding, they need a definitive procedure, but you can temporize them with a pericardiocentesis if you have to.
Nice. So that's what happened with our patient. They did have that pericardiocentesis that we sort of discussed. They got 300 cc's of dark red hemorrhagic fluid. The patient was diagnosed with pericardial tamponade, obviously, and they actually ended up doing well and were able to leave the hospital. I want to thank everyone so much. I put this QR code up while I'm doing the final note here. Thank everyone so much for sharing an hour of your night with us. And I have to say that of all of these that we have done, this has been just such a pleasure, the expertise on this call. And man, this could have easily been a 2 or 3 hour discussion. So thanks everyone. Hopefully this will help all of us, obviously, next time we're at the bedside. And most of our patients, yeah, good. But for those few that we get in this exact situation, hopefully some of the lessons that we've talked about tonight will ring true when we're in that situation. If folks want to join us next time, it's the first Monday of February. And this is, I believe, February 6th, 8 p.m. to 9 p.m. And you can register at the embouncebacks.com. You see on the bottom left there, or that's the QR code for registering for the next one. It's a 59-year-old man with atraumatic back pain and meth use, a patient we've never seen before, right? So thank you again so much, not only to our panelists, but also to all the participants who shared time with us this evening, and we will see you all next month.
Thank you. Thanks, everyone.
That's great. Thanks, Michael. Thanks, Sarah. Thanks for the invitation.
Thanks,
Yeah,
Michael.
so good, guys. Really, really
Thank
good.
you.
I meant what I said. This was really, man, the sharpness and quickness and all the expertise on this line, I mean, really, really rang true. So really great. John, hopefully someday we'll meet in person. I don't think I ever met you in person.
No, absolutely. I'd love that. Maybe we can get you well, that would be a virtual thing. I say virtual over to a conference. I don't know. I'm sure we'll be able to meet in person soon. That'd be great.
Cool. All right, guys. Take care.
All right. Bye-bye.
John, Penn was my stomping grounds. And so I
Oh,
know
what?
my picture's probably still all by the fish tank. So I
Yeah.
was there when the new ED opened and built the residency program. And so I was there a long time ago.
Oh,
Spent 10
yeah.
years there.
It's a lot has changed. Well, it's funny.
Well,
A
trust
lot
me,
has and has not changed. I'm sure.
Well, it's gone through some, there's some wonderful staff and faculty. And so, I was there with Iris and,
She's still there.
those are all Stephanie and those are all I know, those are all
Yeah.
and Amy and, and Steve, I found that the trauma in the ER series, my husband found it, a replay when it was done and I was featured in it and many, many years ago. So it was a wonderful place. So I have great memories. So I'm glad you're carrying things on there because it's good peeps.
thanks,
If you run
Sarah.
into any of those people, say that Sarah said hello, but be well. And thank you, Michael, for inviting us to do this.
Oh, man.
Thank you.
It was my honor is mine. Take care,
Bye,
guys.
guys.
All right, bye-bye.
And I did jump my horse today.
Oh, good. Yeah. And I love that picture you sent. It was awesome. Man, such good
did think
timing
about
though,
it
being able
today.
to see you actually down there and now doing this right in time with us. So it's been a complete pleasure meeting you.
I'm
So
happy.
we're definitely going to keep in touch and do more stuff
Yes.
together, Sarah.
Well, if there's anything that I can help with, I've got lots of time, so I'd appreciate that. I
Perfect.
enjoy it.
All
Thank
right.
you.
See ya.